Good afternoon, everyone, and welcome to Plant-Powered Metro New York's live stream series, Nutrition Heroes in Healthcare. I'm Lianna Levine Reisner, the Network Director of Plant-Powered Metro New York, which empowers people in and around New York City to live their best and healthiest lives with whole food plant-based nutrition. Over the next few weeks, we're talking to some of the people in your neighborhood who are bringing food to the forefront in healthcare. Each of our featured guests is deeply knowledgeable about the power of whole plant foods in health and healing. So we're going to explore their journeys, expertise, and pioneering projects that are changing how clinicians approach patient health and the future of healthcare. Later in the hour, I'll be taking questions from the comment feeds on YouTube and Facebook, so please feel free to share them as we move along. This week, I'm very pleased to introduce you to Dr. Urvi Shah. Dr. Shah is a faculty on the myeloma service in the Division of Hematologic Malignancies at Memorial Sloan Kettering Cancer Center. Her research focuses on studying the role of lifestyle-related risk factors such as obesity and nutrition in the development of multiple myeloma, as well as identifying interventions to improve outcomes for these patients. By being a cancer survivor herself, she is passionate about helping patients make wise nutritional and lifestyle choices as they face a cancer diagnosis, as well as raising awareness about healthy choices to prevent cancer and chronic disease. Dr. Shah, welcome.
Hi, thank you for having me, Lianna. I'm really excited to be here with you.
Excellent. We're so excited you're here. And I'd love for you to share with our viewers today, what was your path to medicine? What brought you into the field and specifically to oncology?
Sure. So I think back in high school and things, I was always interested in science, and I grew up in a family of doctors in India, so that came somewhat naturally, but I was actually better, I think, at math and physics than biology, and I was debating doing that. But then I realized, I also am passionate about interacting with people or making a difference directly to patient lives, or talking to and experiencing, patient direct conversations with patients. And so I thought, medicine would be a better fit for me. And that's how I ended up into medicine. And then once I was in medical school, I think, I'm one of those curious students. And so I pretty much liked everything. And so every rotation I do it, I think maybe I could do this for the rest of my life. And so when I actually had to choose what specialty I'd eventually go into, it wasn't a surprise that I picked internal medicine, because that requires you to have an overall knowledge of every organ system and specialty. So it's a good overall specialty, and not too focused onto one organ system. And then I think, when I was in internal medicine, I again had the next decision point of whether I should do what subspecialty. And I can tell you, when I was in residency, I think with every rotation, I thought maybe I'll do nephrology, maybe I'll do cardiology. And then eventually I settled on hematology and oncology, because I found heme malignancies or blood cancers very interesting. And I do think that, this curiosity for every specialty in some ways helped me get a good foundation or understanding of everything, which has helped me in my career going forward too.
That's excellent. Can you share for our listeners who may not know the field, what is hematologic oncology or hematology, and what kinds of things do doctors do in your field?
Yeah, so hematology and oncology is basically specialists who treat blood disorders and cancers. And in some countries, they are separate fellowships, hematology and oncology. In the United States, it's a combined fellowship for the most part. In hematology, you can be treating non-cancerous blood conditions like anemia, whereas in oncology, you're treating all cancers generally. The overlap comes with blood cancers, which could go under hematology or oncology. And so often you will see specialists who are either a hematologist or an oncologist or both treating them.
And so you've really focused your research lately on multiple myeloma. Can you share, what is it? How does it show up in the population? Is it more common for certain types of people?
Yeah, that's a good question. I think, when you think about blood cancers, the two blood cancers that most people have heard of and come to mind is leukemia and lymphoma. And so myeloma doesn't fit into that, and most patients, many times when they're diagnosed, that's the first time they've heard of it. And actually, myeloma is more common than leukemia, so it's the second most common blood cancer. But for some reason, it's just not as much heard of. And I think part of it could be because the population that's affected is usually an older age group. So the average age is in their 60s. And so it probably doesn't get as much attention in the past because of that. And also, we've now seen a lot of treatment improvements in myeloma. Previously, it was very dismal, like we didn't have much options for patients. Also, a typical patient would be like somebody in their 60s, more often males, but it's even females get it. And what's more interesting about this disease, I think personally, is that it falls under an umbrella of what we call plasma cell disorders. So plasma cells are a type of white blood cell that when they go crazy, you have these plasma cell disorders. And within the plasma cell disorders, you have multiple myeloma, which is the cancerous state, but you also have the precursor situations, meaning like how when we think about breast cancer, we think about DCIS or the precancerous lesions in breast cancer. So in myeloma, we have two entities called monoclonal gammopathy, and we have another one called smoldering myeloma. And why I think this is interesting is because over 3% of the population over the age of 50 have this abnormal protein in their blood or a plasma cell disorder. The thing is that most people don't know because we don't really test for it, because we wouldn't do anything differently if they knew they had it versus not. And so there is a large population of people who have plasma cell disorders, but only a very small percentage of these precursor disorders eventually go on to develop myeloma and need treatment.
That's fascinating. Is there a standard of care for myeloma patients, or is that still?
Yeah. So, for instance, the monoclonal gammopathy or the smoldering, so the precursor states, the standard of care until now has mainly been observation, which is why it's also interesting for me, is because that is a population that, once they know they have it, they are worried about, the small risk that it could progress, and they want to do things. But as of this time, we don't really have treatments for them. So I think that's a very nice population to target with understanding research in terms of the pre-cancer to cancer progression.
Absolutely. I would love to talk more about this. And I think before we go much farther, though, I would like to stop and sort of ask you about your experience as a cancer patient. You dealt with Hodgkin's lymphoma. Where were you at that particular stage in your life?
Yeah, so I was actually a fellow in hematology oncology, ironically, in New York City. So this was at the end of my first year. And it was also when I was on my blood cancer rotation. So it was strange because I was treating patients with Hodgkin's lymphoma, and my initial thought while treating them was, I'm seeing so many different cancers. This is one of the best prognosis or the best outcome cancer. So I didn't feel as, felt like it was such a big impact on their lives, because I thought they're probably going to be cured in a few months. This is a short-term thing and go on. And then just a few months later, I've basically found a lymph node on myself. And then that was a long weekend waiting to, get the scan, because I figured this on a Friday evening. And then Monday I got the scan, and then in a week I had a diagnosis. And I would say that also taught me, that the not knowing is more stressful than knowing and having a plan. And so I try to do that with my patients. So once they come to me, be very clear about what we are planning, what we're looking for, and when we plan to start treatment or things, so that it's not an anxiety provoking time. Because I think the hardest part is not knowing what you're going to be facing going forward.
Yeah. Did it affect your daily life and your career at that stage, or did you keep going on business as usual?
So it pretty much turned everything upside down. I was in a fellowship that's very busy, and most fellowships are. And because of this, I pretty much had to stop for some time to take care of myself. So the patients I was seeing had to be seen by somebody else. And, I had to take a break for a month or so to get at least things going. And I would say eventually in the long term, like after the first month, I went back to work where I was seeing patients once a week instead of the regular 2 or 3 times a week. And I used that as my research block. So I'm kind of, a person who tries to make the most out of most situations, I would say. So I took that opportunity as a time where I'm not really have the energy to go out or meet people or things like that. And so I used it to focus on research. And in one way, it did help me because it kind of expedited my career in understanding research. I was doing it on the side always, but clinical work can be busy. And so this helped move it along much faster. And then I was studying a different blood cancer at that time called adult T-cell leukemia lymphoma, which is caused by a virus, like similar to HIV, but a different virus. So it's actually also, an interesting disease. And we managed to, publish it in one of the top journals, which ended up being a good outcome from everything. But, that was because I decided to, focus my energy on that, then think about, what could be and what else.
I mean, that's amazing. I know for every cancer patient has a different experience, of course. But you were really in the thick of things, being in your fellowship program, and the idea that you even added on research on top of that, it's amazing. And what were some of the strategies that you used personally to help you get through this period?
So I think this is a good question, and I think every person is different, and you have to know what is important to you or what personality you are. I think there are some people who, when they get diagnosed, and this is what I see in my patients too, they want to share it, with everybody, and that social support network of like, on Facebook or Instagram or whatever social media platform they're using helps them feel like they have a community backing them or supporting them. But at the same time, there are some patients who won't even tell anybody, like not even their family members. And I think, somewhere in the middle where I told a few people, but I didn't really want to talk about it to the extended audience. And so that helped me because sometimes, when people want to show empathy or be concerned, it can sometimes be a double-edged sword because it makes you have to also talk about it all the time with people. So I think understanding what kind of personality you are and what would be important, I think, is helpful for any actually medical condition for patients. And this is something I noticed or learned when I was on the other side, and I never thought about it for patients, when I as a physician.
And at what point did you start learning about sort of these lifestyle behaviors that might support cancer outcomes?
So I think as physicians and, we don't really get very significant training, even as oncologists specifically in this. But I would say that, prior to my diagnosis, a few months before too, I had a patient with Hodgkin's who was a young 20-something-year-old patient, and she would come and complain to me how her coworkers and her family members would tell her to eat this and do that, and like trying to control her life with these modifiable risk factors. And at that time, I understand where they're coming from and where everybody's coming from, because when your health is taken away from you, you feel like you don't have control over it and you're at the receiving end of things. So being able to control it with diet and supplements and things feels like, okay, I'm doing something and maybe that will work. And so at that time, I heard that. I didn't think too much about it, and I thought that maybe they are being a bit too overbearing and overwhelming. But eventually, like during my diagnosis, I kind of faced the same thing where I had family members trying to tell me what to do, even though I would tell them like I'm in this specialty and I know what it is. And I think they're all trying to do it from a good place, right? Like wanting to help. So finding that balance, and then eventually in the long term, after my diagnosis and things, then I as I was, recovering from things and finished my treatment, I decided to read more about this topic. And it started kind of strangely more from the environmental aspect of things, where I watched Cowspiracy and, Seaspiracy has more recently been out. And then when I saw that, I was like, okay, I didn't know that, what I eat affects the environment, or I can make a big difference even more than other things through it. And so that's when I started reading more about nutrition. And then that somewhat transitioned me somehow into looking at it more in terms of oncology and how I could optimize it for myself. And then I looked at, and I saw that there are guidelines which we don't really talk about from the American Institute of Cancer Research. The World Cancer Research Fund has this, few 100-page document on different, the evidence behind nutrition that's currently available and things like that. So that's where I eventually ended up realizing that this is a much needed area that and I just did it more as a hobby on the side for many years before I think I transitioned it more into my research and practice. I think that required a little bit of me thinking about it, because I wasn't sure it'll go somewhere or whether that should be my right career path.
Yeah, and I think when we look around at the field, there are not many oncologists or hematologists who are sort of raising the banner for plant-based nutrition. So the fact that you have done so is, I mean, it's been incredible to watch your own path. And I'm curious, when you reflect on your own training in oncology and was there anything related to nutrition in your medical school experience?
No, pretty much. Like, I think, we all have like a little bit of the basics of nutrition, and we had something called preventive and social medicine in India. Like I did med school there, but I think there's similar subjects here in the United States where you learn a little bit about like macronutrients and like, what carbohydrates, fats, and which foods have it and things. But it's not in depth or in detail, and that's the unfortunate part, I think, because the most asked question by patients, I think, is what can I eat or do differently? And I think it's also the least answered questions by doctors. And so when we talk about like why do patients go to other providers and do these alternative things, it's because we aren't having the conversation many times.
Yeah, so when you first came into this area, were you incredulous about what there was to find there about plant-based nutrition and health? Or were you, I mean, it sounded like you were at a point of readiness yourself to hear something different. What did you think?
I mean, I think I always knew there is in the back of my head, like there is a risk or there's an association, but I didn't think that is something that is something that I need to fix or even address or talk to patients about or do anything. Because also, frankly, like, the clinic visits are short. You don't really have time when you're dealing with so many of the acute issues to even add this to one more, issue to deal with often.
Right. So I guess then to transition into talking about your own patients, after you went through this experience yourself, being a cancer survivor, and then, transitioning into plant-based nutrition as your own personal dietary pattern, did this change how you then related to your patients or how you approached caring them? And how long did that process take, I guess, to sort of move toward more lifestyle conversations with your patients?
Yeah, so I definitely, this experience did make me realize like there is an importance to have this discussion than them, and it's better I do than somebody else, like where they read something online and it's not accurate or they start supplement, because I have seen the other side of it too, where, I've had patients who've been on, thought that bone broth is good for their health and like taken bone broth throughout like daily for many days and then come in with abnormal electrolytes. So their phosphorus is off, their kidney function is off because they've taken such high amounts of it. And then I've seen also patients like on supplements end up with liver failure and things. So being able to understand that some of it is good and important, but there is also a balance. And yes, you need the regular therapies, but you could have a complementary look into like what nutrition and supplements could be. And that's the part where I think patients get very confusing information, and so they don't really know what to do, and that stresses them out too.
Absolutely. I think, separate from even talking about lifestyle with patients, are there any experiences that you've had with patients that really left an imprint on you as a healthcare professional?
I would say, yeah, I mean, I think I've kind of mentioned some of them where, the experiences with nutrition or things like that when I had the patient with Hodgkins who had these experiences. So I think, the balance between the judgment versus helping a patient is a fine line that I think needs to be understood by providers and taken into consideration. So I think these small experiences over time, and many of them have shaped it. I also think when I was a patient, like some of the interactions that I had with healthcare providers taught me how I wouldn't want them to be, or how I wouldn't want these interactions going forward. So I think it's over time many different instances of things.
Right. And what has been most challenging for you in working with cancer patients, and maybe specifically multiple myeloma patients?
Yeah, so meaning I think the oncology is challenging because one is that anybody faced with a new cancer diagnosis is going to be very anxious, very upset, very stressed. So you're dealing with that. Then there can be social dynamics at play because this is now stretching their social support system to it. Then there can be toxicities related to the financial aspects of it. So in some ways, a cancer diagnosis can basically turn a whole person's life upside down. So I think that part of it is also difficult as an oncologist to be dealing with. But then I also think that therapies, most therapies in oncology are not short, right? Like they're not like, oh, you do a one-time treatment and you go. It's going to be a few months of treatment, sometimes 6-12 months. So in myeloma, we do 4 to 6 months of induction chemotherapy, meaning the chemotherapy at the beginning, and then we do often a transplant, and then we have maintenance. So this in itself is 6 to 9 months of treatment, and then we're talking about maintenance after, and then maybe future treatment if they relapse. So this becomes something where it does affect a patient's life long term often. And so helping them to get back to their original life and also do this on the side is, can be challenging. And I think that's part of it. And then I would say in myeloma, most of the patients are in their 60s, many 70s, 80s. So as patients get older, they have more medical problems and comorbidities. So I see a lot of patients who have like hypertension, diabetes, obesity, all of these other medical problems that come up to, and so all of that affects or plays into the doses of chemotherapy I can give or how I treat them. And so it requires an individualized plan for every patient, and it cannot be like one size fits all.
Yeah, and I would imagine also the emotional burden when somebody is dealing with multiple chronic diseases could be really high for these patients, adding on a cancer diagnosis as well.
Yeah.
Wow. So, of course, this also then contributes to the emotional burden of what the oncologist and hematologist feels. How do you unwind after a day of working with patients, or after a week of working with patients?
So I think, in this field, most oncologists are pretty good at being able to compartmentalize or empathize for the patient at the time when they are with them, because you obviously do feel it, but you also are able to separate that from being objective and practical, because you need that hat when you're thinking about what treatments and what's right for the patient. Because if you're going to be very emotional about it, you can't make the right decisions for the patient. So I think that balance, most oncologists learn in their fellowship of how to balance the two things and show enough care and concern, but at the same time be able to be practical about what is right to be done as medically for the patient. And for me, after work or things like that, I do enjoy cooking sometimes, and then I also do enjoy like outdoor activities or fitness. So I would say like I do yoga sometimes, or go for a run, or go to the gym. So I switch it up a lot, but I try to do that about 2-3 times a week, or maybe long walks. And then cooking also, it's more like I don't have specific days, but I will do a little bit here and there, when I feel and it's part of, because I think for me nutrition now is something that I see as important, and so I that's just become now part of my life.
Amazing. Yeah. And the self-care piece is so key. I think not everybody realizes that being in the kitchen cooking is a self-care practice too, right?
Yeah. I also think like finding time to have a regular schedule in some ways. So there are some things that are not preventable for me, in the sense like, okay, if I have a conference coming up or a talk coming up or something, that day might be a little more busy. But in general, I try to ensure that I'm sleeping, 6 to 8 hours every night, or around the same time, or things. So keeping that schedule a little bit steady too, I think is helpful in the long term.
That's great. So I guess it might help for our listeners just to hear some of the high level around, well, what do we really know about nutrition and lifestyle as it relates to cancer? What do you think are like the top things that everybody should take away? How much do we know and how much do we not know is also part of that question.
It's a good question. So I think most people, when they have a cancer diagnosis, or even if they hear about somebody else, they're thinking, oh, this is the genetics, or I have some bad genes that caused it. And in reality, about 5 to 10% of cancers are probably hereditary, but the majority are outside that from other factors. And other factors can be things like being overweight or obese. So there are 13 cancers linked to obesity. Myeloma is one of them, which is why also my research in this area makes sense to do. Diabetes is associated with an increased risk of most cancers. We don't know yet whether diabetes truly is causing the disease, in the sense that diabetes related changes lead to cancer, or is it that people who have diabetes have poor dietary habits or something, and those similar factors or genetics or whatever it is are the similar factors that also lead to cancer. And so I think teasing that out, some studies feel it's one way or the other. We looked at it in myeloma in a large Swedish cohort of patients, and that currently we presented it last year. In our study, it seemed like having a diabetes diagnosis just before your cancer diagnosis was most likely. And so there may be a confounding thing of just somebody who gets a new diagnosis of diabetes is now going to get tested or see a doctor, and so get diagnosed with a cancer. But whichever way, I think even with cardiovascular risk factors, there have been studies showing that those who have more cardiovascular risk factors are more likely to have cancer. And I think that's the same thing in that situation. And then when we look at diet, I think overall, one is the American Institute of Cancer Research has these guidelines, and they talk about cutting down on sugary beverages, maintaining a healthy weight, eating more of a plant-based diet or a plant-forward diet, and things like that, which I think most studies across the board are showing this. So there are 3 large studies of over 50,000-60,000 patients that looked at different dietary patterns and said who gets the least cancer amongst those patterns. One was done in the UK, one in the US, and one in France. And all those 3 studies showed that those who ate plant-forward diets are less likely to have cancer by about 15% reduction in all of them, 15 to 20%, depending on the study you looked at. So I think in itself, it says that, and then if you look at individual studies looking at whole grains or fruits, vegetables, and things like that, I think we see the same thing in different diseases. So there is a pattern that's consistent across most cancers, and I think the problem is that most patients I think in the US, a very small percentage, maybe 10 to 20% meet their fiber requirements of 30 grams. So we have moved, like as a whole population, our diet is so skewed now that we don't even get enough fiber for the most of us, the majority.
Right. So, I mean, it sounds like everything we know about these other diseases, fiber is important for cardiovascular disease and diabetes and also cancer. So, of course, I think there's other shades of the cancer experience that often make people wonder, why did this happen to me? And, versus any other kinds of diseases. But maybe it would be helpful if we could sort of talk more about your research into myeloma and nutrition. And we'll keep unpacking some of these questions as we go along.
Sure. So I started out about, I would say 2 years ago in 2019, focusing on lifestyle factors more formally in my research, but it was also a gradual transition because I still do that, but I studied like immune therapies and epigenetics before, and I still do that, but I did start introducing nutrition and metabolic risk factors into my research and looking at those questions. And then over time, I think, one project leads to the other, and the success of those have led to more of those projects. So I think my research has more skewed over the years, and more recently this year to that. In things that I've done so far, where we've looked at, we know that obesity is a risk for myeloma, like I mentioned, but also obese patients are twice as likely to progress from the precursor to myeloma compared to a normal weight patient. And some of this information is helpful for patients to know, not as judgment or blame or things, but things that they could do, because many patients want to know what they can do. And so even though this data is there, I think most patients don't know. Most doctors don't tell them this. So the first thing I did was also trying to get this information out to patients. And so I've done I've set up a nutrition and wellness chapter helped Myeloma Crowd, a foundation for myeloma patients, set up a nutrition and wellness chapter. And with that, what we do is we have monthly talks by different providers on nutrition and lifestyle disorders, specifically targeted to myeloma patients. So I gave the first 2 talks in that series. They're on YouTube if anybody was interested. But we looked at looking at what is known about obesity, diabetes, the microbiome, what is known about dietary patterns, supplements, and things, only what is known so far for myeloma, and just summarizing the data for patients. And so we started with that, and then we looked at obesity after a myeloma diagnosis. So we know obesity before a diagnosis and overall risk with obesity, but we don't know what it does after the diagnosis. And that's something we're, in the process of publishing just now. I mentioned that we looked at diabetes, and then I'm doing a lot of research in nutrition and microbiome as well. So looking at nutrition and its impact on the microbiome, and then its impact on myeloma. And we know that microbiome changes are present in cancer, and we know that nutrition is a big player in what changes are there in microbiome. But connecting all of these is something that we're looking into. And some of the data, actually, we've just finished analyzing, and I'm excited that we submitted it to the International Myeloma Workshop, and we'll be submitting it to other conferences and publishing it soon as well, showing that there is a link.
That's amazing. Are there any specific discoveries that you've made in analyzing the research that you think are instructive for the average person, or is this really much more understanding mechanisms of change?
So some of it is understanding mechanisms, but it also helps to, once you have this data, it helps oncologists and it helps patients, family members know that this is available and this is why I should do something. And it's not just you're doing it because, fruits are good for you, but why are they good, or how do they make the change? And I think knowing why and how is helpful, because a lot of doctors are very skeptical about these large epidemiologic studies, because they say it's an association, but it's not causation. We don't know the mechanisms by which it does this and things. So understanding the mechanisms can actually help put more worth into these associations, or make it more clear that they exist. And so we were also doing an interventional study where It just opened actually last month, and we've had quite an overwhelming response of patients interested in it. But we're looking at patients who have the precursor disorders and giving them a plant-based diet for about 3 months and 6 months of counseling. And then we're following them for a year, and they have to be obese or overweight. So we're just trying to select for a population that might benefit the most, at least in our initial pilot study. And so hopefully by next year, we'll have some data to share on that. And we've got additional funding to fund 2 larger randomized studies. So we're working on that in this area as well.
That's fantastic. I love how you've really started to do this interventional work, which will give us so much more to work with. We know all the population studies, how they point in the right direction, but people really want to see how one thing leads to another. And so the fact that you've gotten this going is great. How many people are you trying to enroll in that research study?
So this study was like I wrote it as a very small pilot proof of concept study. So it's like 20 patients. But since we have more funding, we might just expand the study or write another study. So we're in the process of figuring that out.
That's fantastic. And I'm going to put a link into the chat for anybody who's watching us to follow up and see where they can learn about the study and how they can also support your research.
Thank you. Yeah.
Yeah, absolutely. I'm curious, you're researching how lifestyle intervenes, and, is this a unique thing at Memorial Sloan Kettering for there to be a study going on that focuses on nutrition, or are your colleagues also getting into the game as well?
That's a good question. I think I'm not the only one doing it. I think there is so we have some oncologists in the breast cancer service, the genitourinary oncology service, so the GU oncology service doing some of this. So we have different, but I think what's different is that up until now, most of this research happened in breast cancer, prostate cancer, and there is interventional studies done in that area. And most are focused on solid tumors, colon cancer, all of that. But we don't really have studies being done in the blood cancer space. And part of that is because until most recently, or in the last 10 years, where we've had so much success in therapies, patients didn't live very long. And if they didn't live very long, then focusing on diet or other aspects can be harder when you're focusing on trying to get them better. But as now we've got so many new therapies, I think the survival has exponentially increased for blood cancers, and I think this makes it a place where it's actually important to also study it. And there are other groups at other hospitals looking at it. And so there was one study in an acute leukemia setting where they slightly calorie restricted a patient and improved their diet to the USDA guidelines while they were getting chemotherapy. And they showed that patients who did, and the patients on the study that did that had a higher likelihood of response to the chemotherapy than those who didn't. And so I think now we're starting to see that there might be a role even in the acute setting or interventional setting. And as we see more studies in that space, we'll know. Another thing is that we now have better tools to study it, right? So dietary studies were very hard to do because how you make somebody change their diet and follow it exactly as you want for a certain amount of time. And if you think about cancer, it takes years to develop. So you want them to follow it for years, and then the cost of doing such a study. And so the things that now I think are in our armamentarium are different that help us do such researches, like microbiome changes happen very quickly. So, and microbiome is already known to be associated with outcomes or things, or epigenetic changes or things like that. So looking at biomarkers or markers of the disease instead of looking directly at outcomes can sometimes also be a way to do studies faster or quicker.
Yeah, that's amazing. And then going back to what you were saying about how you can do nutrition changes in concert with chemotherapy, Wendy actually asked us a question. She heard of Dr. Longo's study on fasting and chemotherapy. And have you learned a little bit about fasting or water fasting and its relationship with certain cancer outcomes?
Yeah, so I do not recommend fasting to patients. I think we don't have enough evidence or data at this time. And fasting can be very tricky, especially when you're going through chemotherapy. And sometimes somebody needs to do it in a very controlled manner, because if you're fasting too much, you could be dehydrated, and some of the chemotherapy need kidney function to be normal. And if that's not normal, it'll affect the doses of chemotherapy or increase the risk of toxicity. So I would not recommend fasting at all at this time. But I think what is interesting is that people are starting to look at these things. And so what I would just say at this point is, like, based on how much evidence we have, try to focus on, as much as you can, move towards a healthier plant forward diet. But also, I think, while somebody's going through chemotherapy, that can be stressful in itself. So not to put additional pressure on yourself, like you have to do it now, but to think about it as something, as a long-term plan, right? Like, so if you don't want to do it because you're nauseous, or you have other reasons why you cannot tolerate certain foods, I wouldn't force yourself to do that and, like, unnecessarily lose weight. Because if you're losing weight without a planned weight loss or something, it can actually mean your outcomes could be worse due to that as well. So it is a little bit of a nuance, and there's a lot to be studied in this field. I think in the survivorship space, the guidelines are very clear, and that could be used in terms of what the AICR has out and things like that.
That's great. I'm curious, with all of the work that you've been doing around lifestyle, has this sparked any new discussions or learning among your colleagues into the role of food as medicine for cancer patients?
Yeah, I think it slowly is, and we do have some, we do have some programs related to that in the solid tumor side, looking at, like, optimal health, and there's an optimal living program for the breast cancer patients and things. But I think all of that eventually needs to translate to the blood cancer world too. I think this research that we've done has sparked some discussions amongst my colleagues in terms of things and maybe what they share. So the videos that I had done for myeloma crowd, a lot of my colleagues now share them with their patients too, because that's helpful, for them to just get an overall understanding. And so I think that's one way in which it has created some interest. I also had a colleague once joke with me and tell me that he's never seen such enthusiasm for a clinical trial as he's seen, and he's only seen such enthusiasm when it's like the relapsed patients who have no other options and going on trials, where they are desperate to go on the trials. But this is the other space where he's seen patients that are really desperate to go on this nutrition study that we've opened, and which is interesting to me, because when I opened the study, I didn't know how many patients would actually want to do it or things. But you can see that the patients are also wanting to know more about this, and so that's the nice part about it.
That's great. What do you most want other oncologists and cancer care specialists to consider related to nutrition?
I think don't dismiss it. That's one thing. Two would be, at the least, give the patients information about the American Institute of Cancer Research guidelines. That could be very quick if somebody asks you about it. And if they want to know more, I think all oncologists should spend a little time looking at the data and at least having a 2-minute or 5-minute thing related to whichever cancers they're treating, to be able to tell patients if the patients ask them about it. And then they could also refer them to a dietitian if that's more helpful, or things like that.
That's great. I'm going to try to grab the link from the American Institute for Cancer Research so we can get that out to everybody. They can see what's there. I would love, as we sort of bring this to a close, I want to lighten it up a little bit and just ask you some more, lighthearted personal questions. What are the kinds of things that you like to eat for a typical breakfast or lunch or dinner?
So I think it evolves and changes for me over time, but more recently what I've really started liking is I just now, because stone fruits are in season, I do cut like an apricot or something put like a few tablespoons of chia seeds on it, put rolled oats straight, like I don't even cook them, they're rolled oats regularly, and then I put like either oat milk or soy milk or something on it, and add some nuts as well. So I keep this overnight or even like a few hours, and then just have this bowl of fruit and chia seeds, oats, and milk. I like that a lot. I do sometimes we'll have a multigrain toast with some vegetables or like avocados sometimes or different things. So that would be, I think, my usual breakfast, or then the oatmeal in general. Some of my recipes and ideas, meaning I've just recently started posting on Instagram at Urvi Shah MD. So I just post things that I'm making or recipe ideas that I come across. So
That's great. And how do you snack? What do you do when you're busy and you're, seeing patients or?
So I am generally not a very big snacker, but I do get hungry, and I will make sure that I have my 3 meals every day. So I don't skip meals for the most part. But if I do keep snacks around just in case. Sometimes like work goes late and I can't get to dinner or get to something. And if I'm hungry, then I can't focus and work. So I need to eat something. And so I do keep like bags of nuts, and I do sometimes I think bags of nuts are most commonly, then sometimes popcorn or something else that could be. And other things like if I'm at home and I'm snacking, very often it'll be like carrots with hummus or something like that. So
That's great. This has been so lovely to learn from you and to hear about how you've been pioneering really in the field of hematology and oncology. Is there anything else that you'd like to share with our community?
No, I think we talked about most things, and I'm happy to discuss further with anybody if they have questions. I think it's a field that's just picking up, or hopefully more attention will be paid to it as patients live longer and we have more survivors. So
that's great. Other than the American Institute for Cancer Research, are there particular resources that are about cancer and nutrition that you think are particularly instructive or helpful that you'd like to share?
I think the American Cancer Society has some information too, which can be helpful. I think these are the two main. I do post information on research studies again on my Instagram. Since the last few months, I've been posting. But I think these are the two main organizations that come out with information. Even the MSK website has some information on supplements. They have a good resource where they have like there's a whole database of all supplements that you can go into and know what are the side effects of the supplement, what are the studies that have shown like a good summary of it. So I think those would be the ones that I usually recommend.
That's great. I just realized there's one other thing I really wanted to ask you, because I know when we talk about cancer and nutrition or lifestyle, sometimes it can feel very bad for a cancer patient to, to know that there was something that maybe they did that could have brought about the condition. And of course, that's the case for all diseases, but for whatever reason with cancer, it just feels so much worse. And I think we never want people to feel like they should be to blame for a disease.
Definitely.
So what would you say, or what do you say to cancer patients who feel ashamed or even resistant to hear that there may be that there is a link between nutrition and cancer?
So I think first is to meet patients where they are. So I don't try to force nutrition information on somebody who's not interested in it or don't want to know about it. And there are a lot of patients who want to know and feel like they're not getting enough information. And so those are the ones that I work with, or I will answer questions for them. In general, I completely agree. And that's a very important point, is that, with all diseases, yes, there could be some modifiable risk factors, but the point of talking about these is not to feel like I did something wrong, because that's not always the case. That even nutrition, as we know that it can affect a lot of cancers, it's not always the only reason why somebody has it. And there are many other risk factors. Even like when we talk about obesity increases the risk, it's not the only thing that does it. There are multiple factors combined, and there might be some genetic predisposition, there might be an environmental pesticide or something. Like, we don't always know what's causing it. And so sometimes we just don't have a reason. Somebody's eating well and they still get cancer. So I think taking away the blame from it, and what I basically tell patients often is that, when I'm done with talking about the main part of like the treatment or the plan in terms of the medical management, I do mention to them, sometimes they'll already ask me, like, do you want to do, what else can I do? And then that's a way where we talk about it. And sometimes if they don't ask me about it, I'll say, in case you're curious or wondering about it, there are some links to these specific things in terms of it. If you want more information, happy to discuss. And if it would be helpful, I can send you some links to, information related to it. And so because I treat mainly plasma cell disorders, I find the nutrition links related to the talks I gave, because they summarize most of it, are helpful to patients. So I instead of me having a detailed 2-hour discussion about it, they can just watch it if they want to, and if they don't, then that's their decision too. It's the same with treatment. I don't think we should be forcing anybody. Everyone has their own preferences and choices, but it's our duty, or it's important for me to tell them what I know. So that's what I strive to do.
Amazing. Thank you. Thank you so much for really unpacking the field for us, because there's so many of the ins and outs of how cancer is approached that for people who have, I guess, had the luxury not to go through the process themselves, to learn about it from you has been wonderful. And when I think about the implications for our community writ large on what you're doing, I'm really excited to be able to share back with them in the future, what you're learning through these interventional research trials, and how you're also seeing the field and synthesizing it for people on a really practical level. So that's just so rewarding and really, really well needed in the field. Thank you so much.
Thank you, Lianna. It was really fun talking to you about it. And yeah, I totally agree that, things are hopefully moving forward. I didn't think when I started this that anything would come of it. I said, I'll just do it and see what happens. But I think it's taken off in a way that I didn't expect. So.
That's so exciting. Well, congratulations to you on all that you've accomplished so far, and we'll definitely be watching you. So thank you so much for being with us.
Thank you.
And thank you all for joining us. We hope you'll come back in 2 weeks when we meet Dr. Michelle McMacken, the Associate Professor of Medicine at NYU Grossman School of Medicine and the Director of the Plant-Based Lifestyle Medicine Program at New York City Health and Hospitals Bellevue Hospital. She'll be with us on Tuesday, August 3rd, starting at 12:15 p.m. Eastern. And then our final program in the summer series will feature psychiatrist Dr. Gia Merlot the following week. If you're intrigued about the whole food plant-based movement for health, please feel free to check out our website, www.ppmny.org. You can access our recipe app, PPMNY, in your kitchen. And please be in touch with us with your questions. We are your one-stop shop for information, resources, and action to build really much healthier plant-powered communities. We hope you have a great day.